Hello, and welcome to this HCPLive Special Report. My name is Raj Chovatiya, and I'm an associate professor at the Rosalind Franklin University Chicago Medical School and founder and director of the Center for Medical Dermatology and Immunology Research in Chicago. Today's discussion is focused on the intersection of dermatologic and gastrointestinal care and our evolved understanding of the importance of collaborative care between these fields. In the spirit of collaboration, I'd like to turn it over to an expert who will be joining me today in discussion, none other than Dr. Adelina Hung, an amazing gastroenterologist, also my wife, for those of you that don't know, and I'll let her introduce herself.
Hi, everyone. I am Adelina Hung, and I am the gastroenterologist and hepatologist, as well as the director of the Inflammatory Bowel Disease Program at Sinai Chicago. I'm also the clinical associate professor at Rosalind Franklin Chicago Medical School, and I'm happy to join this discussion here with Raj.
So really what we wanted to try to bring to everyone out there who's wanted to put us into the same room before and see what happens is really talk about our individual medical expertise and how oftentimes we come together when thinking about recognizing shared pathophysiology between our individual disease states and also some of the clinical consequences for diagnosis, treatment, and interdisciplinary collaboration. And I think that hopefully you'll get a pretty good flavor about how we approach things, given that while we serve on faculty at the same university, we practice in very different and diverse settings, and hopefully can come to some common understanding about what we could learn from each other. So maybe I want to toss this to you, Adelina, first as we get cooking. And I want to really sort of understand from your perspective as a gastroenterologist, how do you think about a potential connection, if any, between GI and derm?
Sure. So if we think about common inflammatory diseases, we see commonalities in mechanisms. So if you think about it, we have a common thing where you have a genetically susceptible host and there's an environmental trigger that somehow causes an inappropriate response or an escalated response of the immune system that doesn't turn off or is overstimulated. So in the case of the skin and the gut, if you think about it, they're similar organs. You have like a similar barrier, the skin or the epithelial layer of the gut, that kind of are in constant communication with the environment. The skin is to see constantly protecting it from the outside environment, and the gut, where the epithelial cells are constantly sort of testing the nutrients that we eat or the microbiome or the bacteria that we also come in contact with, the microorganisms we come in contact with in the gut. And somehow when that layer gets disrupted, we can see that below those layers of the skin of the gut, there are a lot of immune cells that are in constant sort of hemostasis with the pro and anti-inflammatory signaling that occurs. So both of these organs are very immunologic active. And once that barrier is disrupted, we see that they can lead to the inappropriate response of the immune system and similar inflammatory markers that get activated. For example, TNF, IL-23, JAK, all of these things are very similar. So that similar mechanism makes sense that, these diseases can coexist because of the similar mechanisms that or inflammatory pathway that can be activated.
I'm going to pause you because that's so interesting, right? Because I think about whenever I'm describing to a patient or another healthcare provider about what's happening in the skin, I really try to divide things into these core pillars that are essentially getting messed up, right? Usually, most of our chronic inflammatory diseases of the skin are either a problem primarily or secondarily with immune dysregulation, some type of barrier dysfunction, something about the microbial, let's say, dysbiosis of the external layer, or potentially something about the nerves or other elements that innervate the skin itself. And, much like you, most individuals are probably really focused on what is coming in contact from the outside with our surfaces, but truly we never really have a very clear answer of that. And so I guess I never really, even though I talk to you all the time, I never really thought that you explain the gut and your diseases pretty similarly to the way we explain our diseases too.
Yeah, there are definitely very similar mechanisms going on. Very similar barriers, very similar immune response, and very similar mechanisms. So if we actually look at the literature and see what kind of studies have been done to look at this association, there are several meta-analysis and systematic reviews that have looked at this association. And yes, they have found that, for example, people with inflammatory bowel disease are more likely to have dermatological diseases such as they're having association with atopic dermatitis, hidradenitis suppurativa, especially Crohn's disease, psoriasis, and that relationship is bidirectional. So also people with these inflammatory skin diseases are also more likely to have inflammatory bowel disease. So yes, there have been this association that has been studied and that does exist.
And I think that from even the other end, right, just even individually thinking about these bidirectional associations, I know we talk all the time, and it's not like something we pick up in clinic all the time, but there's always very interesting extrinsic features of the body that sometimes can tell you what's going on internally. And I say this partially in jest, but it's almost like reading every residency essay for derm is I'm really interested because the skin is the window into what's going on in the body. And whether you're thinking about the manifestations of celiac disease in terms of dermatitis or pediformis, or even certain kinds of alopecia, whether you're thinking about the cutaneous manifestations of liver disease, pulmonary erythema, jaundice, spider angiomas, or even IBD in the case of PG or erythema nodosum, these things do exist. And while we're not necessarily seeing it all the time, it is kind of cool to think about one organ system reflecting and telling us something about the other organ system, but also the fact that there does seem to be this bidirectional association that we don't necessarily understand all that well, but behooves us to really start thinking about some of these cross-specialty conversations.
Yeah, like sometimes, a patient who has celiac disease, their first manifestation could be dermatitis herpetiformis, or even like alopecia could be one of those things too. And sometimes patients, I feel like, are more concerned about their skin, and like that finding made them seek care beyond something like, diarrhea or their GI symptoms. So sometimes the dermatologist will be the first person to see someone who actually has celiac disease or someone who has chronic liver disease and coming to you because they cannot treat their pruritus, okay? Or the pruritus really affects their quality of life.
So what you're saying is that skin is more important than the gut. I think that's what I want everyone out there to take away. You heard it from her.
What I'm saying is that dermatologists need to be aware of manifestations of GI diseases can manifest in skin findings, and they need to be aware of that.
Fair. And I mean, I think that really sort of highlights the importance of cross-specialty conversations. I know we find ourselves in a unique boat because at this point we're sort of stuck with each other. So we have to have, I mean, in general, I think that it would behoove all of us to think about the reasons why it really makes sense. And I think in dermatology, we've spent a lot of years understanding why certain specialties should have some degree of overlap. So the classic is psoriasis and psoriatic arthritis, right? And there are a handful of joint dermatology, rheumatology clinics out there. I think many of us all think about rheumatologists as someone that we're going to refer to for various other systemic and or joint manifestations of our skin diseases. And that's oftentimes the specialty we think about co-managing a patient with. But I would argue that it's actually probably important on a clinical care research and really even pushing the specialty forward standpoint to think about some of the other specialties that deal with some of these chronic immune-mediated inflammatory diseases. And you heard from Dr. Hung, diagnosis, right, is one of those things where definitely one system can inform the other and vice versa. Or frankly, even something as simple as somebody with chronic inflammatory bowel disease or potentially on certain medications may warrant regular skin checks, right? That's another element that thinking about how we're connected together. But even beyond some of the diagnostic cool things you can do with both these different organ systems, shared treatment strategies, right? And I think that knowing that, you heard about some of those pathways and drugs that work on those pathways with TNF alpha inhibitors, IL-23, some cases IL-17, JAK inhibitors, and others. If there was better communication, we may be able to potentially knock out multiple birds with one stone, or feed two birds with one stone, I guess, if we're being a little less violent about it, and really not make one worse. And at the patient level, this is maybe the most important one. I feel like our patients get so much mixed messaging, right? It's very complicated for them to understand who said what and then go talk to this other physician and then this other healthcare provider. And so it probably would help to engender trust and better education, adherence among our patients, and of course, drive forward in terms of research itself. And so maybe we can kind of delve into some of those points, Adelina, and maybe you can tell me your thoughts on sort of the diagnostic part of things and why bringing us together could potentially help diagnosis better.
Yeah, so in terms of diagnosis, like I mentioned before, sometimes someone with a chronic inflammatory bowel disease or a chronic GI disease might first seek care from a dermatologist, um, because they see findings in their skin and that's more visible. So they might see you guys first before the gastroenterologist. So if you don't ask the right questions, like for example, dysphagia for someone who might potentially have EOE or like diarrhea, weight loss, or bloody stool. For some of them, might have inflammatory bowel disease. You might miss that diagnosis, okay? And especially for GI disease, especially for inflammatory bowel disease, early diagnosis is something that is very important because that will change the prognosis of your disease. So, for example, GI inflammatory bowel disease, there's a window of opportunity where you treat a patient early and aggressive enough, you prevent many complications like strictures, abscesses, hospitalization, dysplasia, cancer, things like that. And if you treat a patient later on in the in their disease course where they have complications or they have developed a stricture or had multiple hospitalizations, it's harder for medications to work at that time. So if we catch these patients early and treat aggressively, then you really changing the course of the disease. You really changing the quality of life of this patient. So for us, early diagnosis is so important. So if, as a dermatologist, you can catch that early, get them to a GI, get them to have a colonoscopy, have the diagnosis, you really changing, the course of the disease for this patient. So that is very important.
And I mean, knowing that we may not necessarily always catch these things early and this idea of window opportunity, it's so funny. You would not realize it, Adelina, but most of our skin diseases totally steal the original papers that sort of tried to outline this. And so every disease state, whether it's HS or even atopic dermatitis and others, make a figure that's based on the original GI figure about this window opportunity. And so it's been repurposed many times for skin diseases. But I like this idea that, one disease may sometimes beget or increase risk for the others. So simply intervening early may actually prevent the manifestation of a skin disease that hasn't manifested itself yet, or vice versa, given that our data seems to suggest there is some kind of bidirectional relationship. But even beyond that, if you have a known disease and there's two specialists taking care, treatment, right, is another part of this discussion.
Mm-hmm.
Choosing the right treatment can avoid duplicate therapies, can avoid polypharmacy. You can avoid perhaps unnecessary risk based on treatment choice. You could potentially avoid agents that are going to exacerbate comorbid conditions.
Mm-hmm.
Classic example here is thinking about the choice of IL-17 blocking agents in patients with psoriasis and ones who have risk of inflammatory bowel disease, or potentially even someone who might have risk for, even though we don't understand it that well, paradoxical psoriasis on an anti-TNF. And really, if we sort of choose the right treatments that can really narrowly help everything we want them to help, we could potentially improve prognosis and prevent complications as well.
Yeah, so for GI, at least for inflammatory bowel disease, for a really long time, we never had many agents to treat moderate to severe disease. We have the anti-TNF in the early 2000s, and then we have anti-inflammatory early 2010. So we didn't have that many options, and we are thankfully living at a time where there has been so much innovation in like drug development. In the last several years, we have had so many more medications approved and so many more options. So in the past where, it didn't really matter what medication we choose because we only had like that one or two. And now we have like so many more options. We are in a good position where we can be like, okay, let's think about what other comorbidities this person have, any other things that we can treat together so that, we can improve the quality of life of this patient, prevent having to use multiple treatment for things that is mechanistically similar and can be treated together. So now that we have all of these options, I think it is more critical time that we have to take into account other comorbidities, other specialties, and also have this informed decision. We have multiple specialties come together and decide what's the best treatment, because now we have options, which is great for the patient.
It reminds me of a story of a recent patient that I had who came to see me, and he came to see me for psoriasis that was flaring, and he wasn't doing so great. And he had told me that he actually had a history of Crohn's disease as well. And he also, I think, had probably early signs of joint disease too. And he was telling me that he had been managed on a TNF previously. He had then sort of been off that medication, back on. It really wasn't working for him. And his appointment with his GI doctor was not for a while in terms of trying to figure out what they should do potentially next. And so we talked, and I was like, you know what? An IL-23 blocker might actually be reasonable for you when it comes to thinking about trying to hit all these areas at once. We talked about it, and I was like, I'll try to get in touch with your gastroenterologist, tell him exactly what we were doing. And I was unfortunately unable to, but we still made the decision to go ahead, started him right then and there in the office. And then eventually when he came back to see me, he was like, oh yeah, did my gastroenterologist ever reach out to you? I was like, yes, I got a letter from him telling me that basically he thought I was crazy for starting this man on 2 biologics, including a 23 and a TNF. And he took him off, and he's like, you shouldn't be adding 2 immunomodulators on somebody. And just made me chuckle because I clearly knew what my plan was, and it wasn't that. But that just highlights how sometimes if you don't have really good lines of communication, the patient's kind of wondering what the other doctor's going to think. The other doctor might think that you're out of your mind in terms of making the decisions when the full story is not communicated. The patient's doing wonderfully now and has no signs of gut, joint, or skin disease. And so it just goes to show that a little bit of communication can go a long way, and everyone will respect everyone.
Yeah, in real life, it's so rare that you get to communicate directly, at least GI and derm. And we are lucky that we have each other, but most people, don't even have time to try to attempt to communicate. Like when I put in a referral for derm, because a lot of my patient biologics, part of their health maintenance is a skin check every year for skin cancer. That appointment is not till like a year from now. Like, like that's the difficulty of getting communication with another specialty, especially when we don't have dermatology in our institution. And so, in real life, that communication is not there, which just highlights how important that communication needs to happen. And, and most dermatologists might not be as comfortable as you were, I guess, because you talked to me of like, okay,
So everyone knows she blew up my spot. I did talk to her. I've been doing this since I was an intern in the hospital. She is my Mona friend.
But you know what I'm saying? Like some dermatologists might be like, oh, I don't know what to do with that IVD part. Like I would wait till he sees his gastroenterologist and then go back to me. And then it'll be like, wait, and the patient will be waiting for a long time for any treatment, right? So, that also highlights like as specialties in different field, how some cross training also needs to happen too. Okay.
I can try to give myself a little credit. Didn't you have a story recently about a patient that was on a TNF blocker? That's a good one to share too.
The one with paradoxical psoriasis. Yeah. I guess, talking to you was helpful because first of all, like I wanted to make sure it was PG. Like I thought it was PG, but sharing the picture with you.
I know. It was, you were like, send me a picture. You're like, he came to me, somebody said it was PG, but then somebody said it was psoriasis, and I'm not actually sure which one it is. Is it a papular eruption? And so then we ended up concluding that it was psoriasis. And so then your question was, is this somebody that I can probably get on either a 23 blocker, a 12-23 blocker or something? And would that solve my problems? And whatever ended up happening to that patient?
Oh yeah, so study on anti-IL-23, doing great in both regards, skin and gut. So at least for us, we know that when we have open communication and we can quickly talk to each other and discuss patients, it has really helped our patients, and it had really improve their quality of life. So at least we know that this is important. That's why we know this is important, and
So
we share this. Yeah,
collaborative care is very much like a marriage, is what you're saying. Is that?
for sure, for
I mean,
sure.
even beyond, I mean, all joking aside, even beyond sort of the patient, terms of the piece on really providing good care at the patient level and really trying to choose the right treatment as well. Research is a big thing too, right? We want to have multiple specialties work together. Given that we have joint inflammatory pathways, it's rare that we see trials that really try to take a look at patients with multi-morbidity. And I feel like that's really the future, right? Because we have this idea of many diseases can beget other diseases. And we oftentimes wonder, this is great that my treatment option is in this like patient that has this one disease. They screened out everyone else from the trial. But what about the real world where things get messy and people can actually have multiple conditions going on, right? And we know that many drugs have multiple approvals within spaces of dermatology and gastroenterology and rheumatology and others. But I think that we always still kind of question, which is why we go back to asking each other, I know this is approved for this, but is this the right patient in which I could be treating two things versus not one? And a lot of it is kind of our own anecdotal clinical experience, but it will be cool to see a future where even if it wasn't sort of a basket trial type deal, something that allows us to really think about how we could be treating multiple things in the right patients.
Yeah, and in addition, like, can we track outcomes together? Like, I know in GI we have our own disease activity scores. You guys have your own things like patient-reported outcomes and like how long the treatment lasts, how often we have to switch treatment. So that we never track those kind of outcomes of inflammation together. We might even be able to track them um test for inflammation like CRP or level 2 IL-23 or something like that we can track together. And that can help us just learn more about the disease process, the mechanism, and learn more about inflammation that occurs in a body, as opposed to looking at patients as separate organs. We can see them as a whole, like see them as like inflammation can affect the whole person as a whole, and how we can better treat that person as a whole, because we know inflammation affects multiple areas of the body.
And even though this isn't necessarily the focus of this discussion, even beyond comorbid diseases, our patients are really interested in this idea of the gut-skin axis, right? How often do you get people telling you about their microbial problems in terms of their gut, the dysbiosis, their leaky gut, all these topics that can be somewhat fringe at times, but also have some interesting data behind it well. And I feel like it's impossible for us to really answer some of these questions, in part because there's very little data behind it. So it's another reason why the research matters, because it would actually help to answer some of the most difficult and sometimes a little challenging in a good and bad way questions we get from our patients.
Yeah, no, there has been a lot of interest in the microbiome lately because we have seen a lot of dysregulation associated with multiple diseases, even IBD or things like um, acne or psoriasis or atopic dermatitis for you guys. And, there are certain um, treatment in the microbiome that has kind of like sometimes help in the GI front. For example, like the fecal microbiota transplant for C. diff infection for us, or something like BSL-3, which is one of the probiotics that have helped with something called pouchitis in inflammatory bowel disease. So there is a lot of promise that somehow um, researching the microbiome and giving treatment in a way to help change the microbiome can be helpful with those diseases. And we have seen that it has helped in a couple of GI diseases, but I still think there's a lot of promise, but still we're not there yet. And I do think that in the future, where with clinical trials, that's something that we should also look into. That should be part of clinical trials, trying to measure the changes in the microbiome.
I mean, this point about research and clinical care, it really funnels down to the patients at the end of the day, right? And it's because the fact that if we work together, just care becomes that much better. There's less fragmentation. People feel like they're not bouncing between specialists to get answers or different answers to find the answer they want for their question. If we were all on the same page in terms of how to answer some of these questions about treatment choice for multimorbidity, some of these tricky questions about the connection between the gut and the skin itself, I think it just engenders more trust in us as specialties and gets people much more likely to adhere to our plan of action. And that kind of brings me to maybe sort of one of my closing questions that's rattling around in my mind. What do you see as some of the biggest unmet needs, Adelina, when we think about GI and dermatology and that intersection?
Um, so I think one of the things we need is better education. I think I early talked about how there has to be some cross-disciplinary training, okay, among the two different specialties, so that we can kind of make sure we getting the diagnosis early, the correct diagnosis, or like coexisting diagnosis together quickly, so that because we know that when we have this collaboration with and when we treat these patients that have comorbid or coexistent diseases, their treatment improves their quality therapy have collaboration. So if I can think about the last time I had a dermatology training, I don't know, it's probably like medical school, maybe somewhat in internal medicine residency, but since then in GI we don't really get that much training in dermatology, and I don't know, but you guys are probably the last time you had like some sort of ask some sort of GI questions, probably, I don't know, intern year or something like that.
Almost never. These questions are not getting asked much in the dermatology world. And you're right, that education point would be helpful for both of our specialties, knowing that at the end of the day, people are coming to see us not specifically for other organ systems, but the right questions and the right type of exam findings to be on the lookout for could really have immense value in terms of thinking about how and when we refer and treat. And I'll add another point to your list. I'll say that there's this idea of guidelines and protocols, right? There's these questions that don't have very clear answers. When do I refer? How do I co-manage biologics or oral therapies or immunosuppressive therapies? Who's supposed to be monitoring the disease activity? Which one takes priority whenever there's two diseases together in terms of the one that really needs the control versus one that's going to secondary on
Mm-hmm.
ride itself? How should we be following up and in what interval? How should we be choosing a therapy that does not have a deleterious effect on one organ, even if it may benefit the other? How do we really formulate these common messages about managements and maybe come in with these joint guidelines? There's no real answers to these questions other than
Yeah.
really, this is how I do it. So I feel like that would be really cool to come together and do.
Yeah, for sure. I think like I said, right now we are living in a moment where we have so many more options in treating patients. So that's why all of these questions are coming up. So this is like the best time to kind of like think about, yeah, we probably need to have something more standardized so that so like patient can get the best care they can get, so that they can get the best treatment for both disease processes.
We also know that there's similar disparities in our specialties. This is something we talk about all the time in terms of the patients that we see in Chicago, but even sort of research that we've done as well, in that there is an increasing prevalence of a lot of these diseases amongst groups that either have the least financial resources, living resources, patients that identify with certain racial and ethnic groups as well. And it's another point that I think that if we're really trying to address the conversation behind why there is either inequitable care or outcomes, focusing on single disease states and or single organs probably also is not going to fully address that problem for many patients.
Yeah, for sure. I mean, like if you think back when we were in medical school, for example, inflammatory bowel disease, it was thought to be just a disease that affects Caucasian, right? Or mostly, your board question for someone who has IBD would be Caucasian or maybe Ashkenazi Jew or something like that, right? So, but now we have seen like this an increasing trend, like exponentially growing, where we see other ethnic minorities, that all the racial groups that have had increasing prevalence exponentially for inflammatory bowel disease. So we are recognizing that for other other factors, most importantly, like the social determinants of health, access of care, all of other things, have caused us to not think of these groups, but that now it's being recognized that yes, all these people are being affected by inflammatory bowel disease, and so it is essential for this group of people who have barriers of care, who don't always can get a comprehensive treatment plan. It is essential that that a specialty communicates so that they have a common message, a comprehensive treatment plan. So these vulnerable population are probably most at risk of also falling into this fragmented care.
I like it. Well, I mean, maybe we can wrap things up and really think about how us working together has really helped our patients. And I know that I can start by saying that there's been a lot of patients along the way that have had signs and symptoms that I'm not exactly sure of what to do with, what's important, what's not. And you've always been there to help me say, definitely this is a patient that needs a referral. Definitely this is a patient that can wait, but just get it cooking. And this is somebody you can go forward with treatment. And I think that it would be so important for people out there to really think about why awareness of collaboration is so essential, right? Because it improves early diagnosis. It helps us coordinate our treatment. We get better holistic patient care. And it's just so exciting that we have treatments that allow us to bridge some of these gaps that we're now beginning to understand how we can help patients as a whole, as opposed to in silos.
Yeah, so like most of my patient population are from underserved areas where they have a lot of barriers of care, and where they don't always get the treatment early on, or like they have more complex disease. So that collaboration with you, especially when we don't have a dermatology on site, has been really great in making sure that my patients get the best treatment possible, and that we are treating them as a whole, several disease processes that coexisting together, rather than individual organs. And I think it is exciting that now we are beginning to recognize that we need to treat patients, as a whole, like common, where instead of separate organ system, we are treating them as like, similar mechanism can affect the body in multiple organ system, and we can treat that as a whole. So I think that is an exciting time. And thinking about hopefully in the future, we are designing, or near future, we are designing better clinical trials that can be inclusive of everyone, inclusive of what we see in the real world, which is, patients who are not from only one racial background, and patients who have multiple comorbidities, included in clinical trials. And how great will it be that we can, follow outcomes from two different specialties, so that we can learn more on how we are best treating these patients. And also how we are recognizing that young doctors, like in the future, need to systematically think of a person as multiple organ systems, not just one, and be better trained than us, like where they can recognize findings that, might not relate to their own specialty.
I love it. Well, thank you so much for this awesome conversation. It's nice for people to get a peek behind the curtain of maybe some of the things that we talk about on a day-to-day basis. And I know that they're going to really, really appreciate mainly your insights that they're hearing here today. So again, a big thank you to you, Dr. Hung, for joining me. I'll see you at dinner time. I'm kind of curious when I eat, but that's a separate point altogether. And thank you all for the audience to listening to us in this fun conversation for this HCPLive Special Report. And hopefully we'll get the chance to do it again. Goodbye.
Thank you.